Thank you for joining us on our presentation for neurocognitive disorder. This evening our focus is on dementia. My name is Amanda and I will be introducing an overview of dementia during the first part of this presentation. The first thing that I want to go over is where to find dementia in the DSM. In the DSM-4, dementia could be found under the category of dementia, delirium, anesthetic, and other cognitive disorders. Now in the DSM-5, dementia is no longer a specific diagnosis, but it can be referred to under the major neurocognitive disorders. The DSM-5 understands the importance of using the word dementia for clinicians and physicians, and recognizes that dementia is usually used towards the neurocognitive disorders such as Alzheimer's or Lewy body's disease, as they tend to relate to aging, whereas all other neurocognitive disorders, it can happen to anyone during any age. For example, a brain injury, a 20-year-old experiencing a brain injury can exhibit neurocognitive disorder. So what is a major neurocognitive disorder? It's a deterioration of a cognitive function resulting in a decline of performance in at least one of these cognitive domains. An example of a cognitive domain is executive function. Executive functioning is how we make decisions, process it, or is decision making and planning. Whereas learning and memory is how we gather information and then process it, and the executive function then decides how we use that information that we've gathered. One of the major, when assessing for a neurocognitive disorder, it's very important to look at the functional impact of the disease, as it usually has an impact on either the activities of daily living, such as eating or dressing, bathing, but also can have an effect on the instrumental activities of daily living, such as bill pays, home maintenance, being able to plan things out like shopping lists or laundry. The other specific things in terms of assessing for major neurocognitive disorder is that there comes with a specification of with or without behavioral disturbances. So with this diagnosis of neurocognitive disorder, you may see that no behavioral disturbances, or something such as agitation, hallucinations, aggressive behaviors. The last section, or the last part to consider when assessing for a major neurocognitive disorder, is that you need to specify the severity. This usually has, that could be mild, moderate, or severe. This usually has to do with how the extent of the decline of the cognitive domain and how that decline has impacted the function. So, for instance, you may diagnose someone with a mild neurocognitive disorder based upon if they just need some assistance with bill pay because they're having difficulty remembering their bills. Whereas moderate would be that because of their inability to process certain information or to plan certain information, they can no longer pick out the outfits and put on their pants because they just can't, they don't have, that's where you start to see the decline in the activities of daily living. And then severe would be someone who is completely dependent in all everyday activities. So when assessing someone specifically for a neurocognitive disorder or dementia, there, as mentioned before, are several subtypes. These subtypes are distinguished on the basis of a combination of time course, characteristic domains affected, and the associated symptoms. No matter what the neurocognitive disorder is, however, or a subtype, it has to meet the previous criteria as described on the previous slide. So here you see two examples. One is Alzheimer's disease. In addition to having to meet, as I said, the earlier criteria, there also needs to be, well, there are three things that need to be found true. One is a decline in memory and learning, plus one other cognitive domain. So that could be the executive functioning. That could also, for instance, you also have to see the disease has to be progressive. So meaning that over time, there it goes from mild to moderate to severe in terms of the symptoms of the disease. And all other possible dementia subtypes need to be rolled out. So the big difference then, in addition to diagnosing the subtype, you go into the possibility of probable versus possible. Probable means that there's much more likely of the chance of the Alzheimer's disease being an accurate diagnosis. For Alzheimer's, there needs to be a genetic trait or family history. While all of the three, as I said, listed above, need to be true, or for it just to be a possible diagnosis of Alzheimer's disease, genetics must be there in order to be considered a probable diagnosis. The second subtype is vascular neurocognitive disease. This is related to a cerebrovascular event, or also known as a stroke. There needs to be some sort of evidence outside of the signs and symptoms, such as neuroimaging, family history. This could even just be a physician who had worked with the client before the stroke and then worked with them afterwards and had observed a change in their signs and symptoms or their cognitive function. In terms of the cognitive domain that needs to be affected, there needs to be a decline in the complex attention and also the frontal executive function. So this would be more your processing of information. The difference between possible versus probable is that there needs to be a genetic or physical evidence outside of the signs and symptoms. So, for instance, instance would be a neuroimaging. So it's possible that someone could have vascular neurocognitive disease without this evidence, but it's the disease, the diagnosis is more likely to be probable with that corroborating evidence. And I mean, there are multiple reasons why this could or could not happen. One is that it might not be evident on the slides. Two is that you may have a client that is refusing to go through the procedure of a CAT scan. And so neuroimaging is just not simply possible. Here I've added a video, and it's a video where Dr. Lee Harper is conducting an assessment on an individual who they assume has dementia. And what you will witness is how he not only completes the assessment in terms of what specific questions, but how after he asks a few questions, he then guides his assessment to very specifically find out where the decline is in terms of the cognitive domains. So not only can he then diagnose this woman with a neurocognitive disorder or dementia, but he can also find the specific subtype in order to then respond appropriately with the proper treatment or behavior modification program. So that is the end of the first part of this presentation. Rachel will continue with her second part, presenting a article and a few additional websites where you can find resources for both information and resources for caregivers. Thank you. That was